Imagine you are staring at an MRI scan of your own spine.
Right.
It is up there on the light board, and you see all these ghostly gray and white shapes. And you have been waiting weeks for this appointment.
The waiting is always the hardest part.
It really is. You are currently in so much agony that you can barely even sit in the plastic chair in the examination room.
You are just completely exhausted by it.
Exactly. So you are bracing yourself for the worst. You are thinking it is a ruptured disc or a tumor or, something requiring intense surgery.
Something with a clear physical fix.
Yes, exactly. And then the doctor walks in and they are smiling.
Which is never what you expect.
Right. They clip another scan up, they point to the pristine alignment of your vertebrae, and they say, great news, your back is perfectly healthy.
Your scans are completely normal.
Your scans are completely normal, but you are sitting there radiating pain. And in that moment, the word normal does not feel like a relief at all.
No, not at all.
It feels like a dismissal. Honestly, it feels like you are losing your mind.
It is one of the most profoundly alienating experiences a human being can go through. I mean, truly.
It has to be.
When your internal reality, which is this inescapable screaming pain in your body, is completely contradicted by the external medical evidence, you were told there was no physical reason for you to be suffering.
But the suffering is the most real thing in your life.
Exactly. It is entirely real to you.
Today, we are validating the millions of people living in that exact nightmare. If you are listening to this right now and you are dealing with chronic pain, we are dedicating this entire conversation, this whole deep dive, directly to you.
It is so important that we talk about this.
It is. We are going to unpack a massive, truly revolutionary paradigm shift in modern medicine.
A total game changer.
We are talking about a newly recognized official third category of pain. It is called nociplastic pain.
Right. Nociplastic pain.
And our mission today is to give you, the listener, a comprehensive, deeply empowering understanding of what is actually happening in your body when pain stops being just a symptom of a localized injury.
And actually transforms into a systemic disease in its own right.
Yes, because when I first started looking into the neurobiology of this for a deep dive, I just felt this overwhelming wave of relief.
It is incredibly validating for so many patients.
Just to think that the medical community finally has a name and a diagnostic framework and a biological explanation for something that affects so many people.
Well, understanding this distinction changes absolutely everything.
Oh, so?
It is the dividing line between years of frustration and finally finding a real path forward.
Right.
I mean, it explains not only why you hurt, but why the surgeries did not work or why the standard painkillers might actually be making you feel worse.
Wow.
And most importantly, it shows what a legitimate, biologically grounded treatment plan actually looks like.
To use a really simple analogy right out of the gate, looking for the source of this kind of pain with an MRI machine or an X-ray, it is basically like looking for a cracked screen on a computer when the actual issue is a deep glitch in the operating system's code.
Oh, that is the perfect lens for this, the hardware versus software analogy.
Right, because the hardware is perfectly fine. The software, however, is just caught in this endless, agonizing loop.
Exactly. And to truly appreciate how monumental this new third category of software pain is, we really have to look back at the history of pain medicine.
Right. Let us set the stage.
For centuries, going all the way back to Descartes in the 1600s, medicine viewed pain as a straight line, like a 1-to-1 ratio.
You pull a lever at the foot, and a bell rings in the brain.
Yes. And up until very recently, doctors essentially tried to force every single patient's pain into two distinct hardware-based buckets.
Okay, let us walk through those traditional buckets, because if we are going to understand the software, we need to know the hardware.
Exactly.
The first one is the one we all learn as toddlers, basically. Nociceptive pain.
Right. Nociceptive pain is the quintessential hardware problem. You have these specialized sensory nerve endings scattered all throughout your body. I mean, they are in your skin, they are embedded in your joints, they even wrap around your internal organs.
And these are called nociceptors.
Yes, nociceptors. And their entire job, their only purpose, is to detect actual tissue damage or the immediate threat of tissue damage.
Like, for example, putting your hand way too close to a campfire.
Exactly. The extreme heat threatens to burn your skin. So the nociceptors detect that thermal threat.
Right.
Or, consider something internal, like severe osteoarthritis in your knee. The cartilage is worn away, the bones are literally rubbing together, and there is massive localized inflammation.
Ouch. Yeah.
The nociceptors in that joint detect the inflammatory chemicals and the mechanical destruction. They fire off an electrical signal. They send it zooming up the peripheral nerves right through the spinal cord and into the brain.
And the brain receives the signal and basically translates it as, hey, danger in the left knee, protect the left knee.
Precisely.
So it is a highly localized, completely rational warning system. The punishment fits the crime, so to speak.
It is entirely proportional, yes.
You sprain your ankle swells up, and it hurts exactly where the actual damage is located. So that is bucket number 1, nociceptive pain.
Right.
Then, historically, if a doctor could not find a swollen joint or a broken bone to fit into bucket number 1, they moved on to look for bucket number 2, which is neuropathic pain.
Yes. So if nociceptive pain is a damaged joint or burned skin, neuropathic pain is a damaged wire.
A damaged wire. I like that.
The tissue itself might be fine, but the actual nerve communicating with the brain is visibly, measurably injured.
Okay.
It is pain caused by a direct lesion or disease of the somatosensory nervous system itself.
I always think of sciatica for this one.
Sciatica is a textbook example.
Because someone has a bulging disc in their lower spine, right? And that disc physically presses down on the sciatic nerve. So the leg itself is perfectly fine. There are no cuts, no bruises, no sprains. But the patient feels this blinding, shooting pain going all the way down to their calf.
Because the wire is pinched at the source.
Exactly.
Makes total sense. Another really common example would be diabetic neuropathy.
Oh, right.
In that case, chronically high blood sugar levels actually become toxic to the delicate nerve endings in the feet and hands, and it causes them to physically deteriorate.
Wow.
The myelin sheath, which is basically the insulation around the nerve, it starts to break down. And doctors can do nerve conduction studies and literally measure the slowing down of the electrical impulses.
So they can physically see the damage to the wire on a test?
Exactly, they can point to it.
So for the vast majority of modern medical history, you go to a clinic in pain, and the doctor just plays detective.
Right.
They look for tissue damage. That is the nociceptive bucket. And if the tissue looks good, they look for nerve damage, the neuropathic bucket.
That was the entire playbook.
But what happened to the millions of people who had no joint deterioration, no inflammation, no pinched nerves, and perfectly normal nerve conduction studies?
Honestly, they were completely abandoned by the diagnostic framework.
That is heartbreaking.
It really is. Their conditions were slapped with labels like idiopathic, which is basically just a fancy Latin way for a doctor to say, well, I have absolutely no idea what is causing this.
Right, just covering their bases.
Or they were told they had dysfunctional pain syndromes. And the result of that was just incredibly disjointed, often truly harmful patient care.
Just bouncing around from doctor to doctor.
Exactly. There were shuffles from specialist to specialist. They were endlessly retested. And frankly, they were frequently dismissed.
Which brings us to the year 2017. This was a monumental shift in how human suffering is categorized.
It was huge. The International Association for the Study of Pain, which is the leading global scientific body on this topic, they finally updated their taxonomy.
It is about time.
Right. And they officially recognize a third mechanistic descriptor for pain. They named it nociplastic pain.
Nociplastic, I mean, it is a very heavy clinical word. Let us decode it for the listener. What does that actually mean at a base physiological level?
Well, the formal definition is pain that arises from altered nociception.
Altered nociception.
Yes.
Yeah.
This means the nervous system itself has completely changed how it processes sensory information.
Okay.
It is actively amplifying signals. It is creating pain that is totally out of proportion to any stimulus.
But without any actual damage.
Exactly. Despite there being zero clear evidence of actual tissue damage threatening the nociceptors and zero evidence of a severed, compressed, or diseased nerve.
Okay, so the system that processes pain has fundamentally changed its own function.
That is exactly it.
Going back to our house alarm analogy, the alarm system is blaring, the strobe lights are flashing, the sirens are deafening.
But there is no burglar at the window.
Right. And the wires connecting the alarm system haven't been chewed by mice or anything. The control panel itself has just become hypersensitized to the entire environment.
That captures the essence of it perfectly.
It is just a glitching control board.
Yes. And prior to 2017, this concept explained the totally unexplainable.
Like what kind of conditions?
Things like fibromyalgia, irritable bowel syndrome, temporomandibular joint disorder, TMJ.
Oh, yeah. TMJ is awful.
And honestly, a huge percentage of chronic, non-specific lower back pain, we just did not have a mechanistic home for them before. Now we finally do.
Okay, hold on. Let me just channel the skepticism of someone who has been fighting with their doctor for 10 years right now.
Please do.
You're telling me that there's no tissue damage,
Right.
and you're telling me the nerves aren't severed or diseased.
That's all right.
Isn't that exactly what terrible, dismissive doctors used to call hysteria? Or, psychosomatic pain? I mean, isn't this just a new, polite medical way of saying it is all in the patient's head?
I am so glad you asked that, because that is the single most destructive, pervasive myth surrounding chronic pain, and we need to obliterate it right now.
Let's do it.
Nociplastic pain is absolutely not a psychological invention. It is not a mood disorder that is just masquerading as physical pain.
Right.
It is a biological, measurable rewiring of the central nervous system. The pain you feel is 100% as real as the pain of a compound fracture.
Wow. Okay, so the distinction isn't whether the pain is real or fake. The distinction is simply where the pain is being manufactured.
Exactly. The
Mm.
source of the pain is centralized in the brain and the spinal cord, rather than being localized in the peripheral tissue of your knee or your back or your gut.
Right, right.
To tell a nociplastic pain patient that their pain is just psychological, just because their knee joint looks fine on an x-ray, is a profound failure of medical understanding. It completely ignores the complex neurobiology of the brain.
Hearing that laid out so clearly, I mean, that has to be life-changing for someone who has been gaslit by the medical system for years.
It is often the first time they feel truly heard.
The pain is real. It is just being generated by the control center. So, for the person listening right now, how does this actually manifest in daily life?
Well, it looks very different from traditional pain.
Right, because if the control center is glitching, it is not just going to feel like a standard sore muscle, is it?
Not at all. Because nociplastic pain originates in the central nervous system, which is the overarching network that governs your entire body. It creates a very specific and historically very confusing clinical picture.
So it's a whole cluster of symptoms.
Yes, the symptom cluster goes far beyond just hurting in one spot.
Let us break down that clinical picture, starting with just the nature of the pain itself. Because if I sprain my wrist, the pain is at my wrist. I can point to it with one finger. But nociplastic pain behaves completely differently.
It does. It is characteristically widespread or regional or multifocal. It flat out refuses to obey the standard anatomical boundaries that doctors are taught in medical school.
What do you mean by boundaries?
Well, a patient might describe a deep, dull ache that starts in their lower back, right? But then, maybe a week later, it seems to have migrated completely to their shoulders or even down both of their legs.
So it crosses the midline of the body.
Frequently. A pinched nerve in your spine usually causes pain down one specific leg, and it follows a very predictable roadmap of nerve endings called the dermatome.
Okay.
But nociplastic pain, it doesn't care about dermatomes at all.
It just goes wherever it wants.
Exactly. It is a global broadcast of distress. It can affect the upper and lower halves of the body, left and right sides, simultaneously.
That migrating nature is fascinating. It is almost like a thunderstorm moving across the landscape of the body.
That is a great way to picture it.
But honestly, looking at the clinical criteria in the sources for this deep dive, it was the non-pain symptoms that I found the most revealing.
Oh, absolutely.
The things that seem entirely unrelated to a sore back.
Right. The non-pain symptoms are the glaring red flags that the central nervous system is in overdrive.
So what is happening there?
Well, when the brain and spinal cord are constantly generating and amplifying these massive pain signals all day long, it consumes an immense amount of metabolic energy.
Sure, it takes fuel to run the alarm.
Exactly. And the immediate result of that constant energy drain is systemic crushing fatigue.
Now, we really need to distinguish this from normal tiredness, right?
It's very important.
Because this isn't just, oh, I need an extra cup of coffee because I stayed up late watching a movie.
No, we're talking about pathological exhaustion here.
Oh,
The kind of fatigue where just taking a quick shower feels like running a marathon, and you literally have to lie down in bed afterward just to recover.
wow.
It is an energetic depletion at a cellular level, and inextricably linked to this fatigue is the quality of the person's sleep.
Unrefreshing sleep. You could be totally unconscious for 10, 12 hours and wake up feeling like you were in a car crash.
Exactly. The central nervous system is so hyper-aroused, it is so on edge, that it prevents the brain from dropping into those deep restorative stages of slow-wave sleep.
So your eyes are closed, you are asleep, but your brain is essentially still on high alert.
Right. It never fully shuts down.
Yeah.
And then, of course, you layer cognitive dysfunction on top of the fatigue and the pain.
Brain fog.
Brain fog. It is the perfect colloquial term for it.
What does that actually look like for a patient?
Well, patients describe losing their train of thought mid-sentence, struggling to recall really basic words, or just finding it impossible to concentrate on a simple task, like reading an email.
It just wipes out your working memory.
Severely compromises it, yes.
I mean, if your brain is constantly processing an imaginary fire alarm in the background, it obviously does not have the bandwidth to remember where you put your car keys.
It makes complete sense biologically.
It really does. And naturally, dealing with all of this day in and day out takes a massive toll on mood.
Anxiety and depression are highly comorbid with nociplastic pain.
Of course.
And it is crucial to understand the causality here. While severe depression can technically lower a person's physical pain threshold, very often these mood disturbances are a direct consequence of living with relentless, unexplainable pain and profound fatigue.
It is not the cause, it is the result.
Right, it is a completely rational psychological response to a devastating physiological reality. If you hurt every day and no one believes you, of course you're going to be depressed.
Absolutely. But there is another symptom here that really crystallized the whole concept for me when I was prepping for this deep dive. Multisensory hypersensitivity.
Yes.
It's not just the pain pathways that are dialed up.
No, the entire sensory apparatus is amplified. The central nervous system isn't just turning up the volume on pain, it is turning up the volume on literally everything.
Wow.
People with nociplastic conditions frequently develop photophobia, where normal room lighting feels blinding or triggers terrible headaches.
It's a normal lamp.
Just a normal lamp. And they develop phonophobia, where a loud TV or a passing siren isn't just annoying, it is actually physically distressing to them.
And strong smells, too, right? Like perfume or cleaning products can suddenly induce intense nausea.
Exactly. The brain's threshold for what it considers too much input just plummets across the board.
And this extends to physical touch as well, which results in a phenomenon known as allodynia.
Yes, allodynia.
Allodynia is basically when things that absolutely should not hurt somehow do.
That is the clinical definition in a nutshell. It is the sensation of pain in response to a stimulus that would normally not provoke pain at all.
Give me an example of that.
Well, for someone with allodynia, just the gentle weight of a bedsheet resting on their legs can feel like burning needles.
A bedsheet.
Yes. Or a hug from a family member can cause agonizing muscle pain. The tag on the back of a shirt feels like coarse sandpaper.
If we go back to our house alarm analogy, it is like the sensitivity dial on the motion sensors has been cranked up to absolute maximum. The alarm is designed to go off if a burglar smashes a window with a crowbar. That is normal nociceptive pain.
Right.
But with nociplastic pain, the dial is so incredibly sensitive that the alarm triggers, the police are called, the sirens are blaring, all because a single leaf blew against the glass or a loud truck drove past the driveway.
It is an indiscriminate threat response. And because that central alarm system regulates the entire body, patients rarely present with just one single issue.
Which leads us to a phenomenon heavily discussed in modern rheumatology: chronic overlapping pain conditions, or COPCs.
COPCs, yes.
This honestly blew my mind because it completely exposes the flaw in how our entire medical system is compartmentalized.
It really highlights the blind spots in modern medicine.
Walk us through a typical patient journey with COPCs. Let's invent a composite patient.
Okay, let's call him David.
David, let's talk about David.
So David is in his early 30s, and he starts experiencing severe cramping abdominal pain and completely unpredictable bowel habits.
Sounds awful. So he goes to his doctor.
Right. He goes to his primary care doctor, who predictably refers him to a gastroenterologist. The gastroenterologist runs an endoscopy, a colonoscopy, orders tons of blood work.
And what do they find?
Everything comes back totally normal. So the specialist diagnoses him with irritable bowel syndrome, or IBS, gives him some dietary advice, and sends him on his way.
Okay, so David has a gut problem.
Right. But a year later, David starts getting blinding, throbbing pain on one side of his head, accompanied by nausea and extreme sensitivity to light.
So he goes back to the doctor.
He gets referred to a neurologist this time. The neurologist orders an MRI of his brain to check for tumors or aneurysms. The MRI is perfectly clear.
Right.
So the neurologist diagnoses him with chronic migraines, prescribes a specific medication, like a triptan, and sends him home.
Okay, so now David has a gut problem and a brain problem.
And then, 2 years after that, David develops widespread, deep aching in his shoulders, his hips, his lower back, and he's exhausted all the time.
So another specialist.
He gets referred to a rheumatologist. The rheumatologist tests him for lupus, rheumatoid arthritis, all the standard autoimmune markers.
And I am guessing the blood work is negative.
Completely negative. The rheumatologist does a tender point exam and diagnoses him with fibromyalgia.
So, David now has three separate doctors, three separate specialists, treating three seemingly entirely different diseases with three different sets of medication.
But what the Nociplastic framework reveals is the unifying theory of David's suffering.
Which is what?
It is highly likely that David does not have three distinct diseases at all. He has one underlying mechanism, central nervous system sensitization.
Wow.
The alarm system is simply manifesting as hypersensitivity in the nervous system of the gut, and then the nervous system of the head, and then the nervous system of the musculoskeletal tissues simultaneously.
It is the exact same fire, it is just burning in different rooms of the house.
That is exactly right.
And the tragedy here is that the gastroenterologist is only looking at the kitchen, the neurologist is only looking at the attic, and nobody is going downstairs to look at the electrical panel in the basement.
Exactly. It requires a massive paradigm shift in clinical practice. You cannot effectively treat the gut, the head, and the muscles as isolated hardware problems when the software running all three of them is fundamentally corrupted.
Okay, so let's go down into the basement. Let's look at the electrical panel. What is actually happening inside the control room, meaning the brain and the spinal cord?
Let's get into it.
We keep using the term sensitize, but let's dive into the hard neuroscience of central sensitization.
The neuroimaging data that has emerged over the last 2 decades is just staggering.
What are we actually seeing in the brain?
Well, with the advent of functional MRI scans, we can now observe the brain, not just structurally, but metabolically. We can literally watch it process pain in real time by tracking blood flow and oxygen usage. And what we see in the brains of people with nociplastic pain is profound hyperreactivity. The brain is literally amplifying the incoming sensory signals.
And it isn't just the quote-unquote pain center of the brain lighting up, right? Because the literature talks extensively about large-scale brain networks acting strangely. The term they use is brain network enmeshment.
Yes, enmeshment. The brain does not just have one single spot that says ouch. It operates using vast, interconnected networks of neurons that communicate across entirely different regions.
Right.
To understand enmeshment, we really need to understand three specific normal networks: the default mode network, the salience network, and the sensoromotor network.
Okay, let's break those down for the listener. What is the default mode network doing in my brain right now?
The default mode network, or DMN, is basically your brain's background state.
Yeah.
It is highly active when you are awake, but resting, not focused on the outside world.
Like when I'm just zoning out.
Exactly. When you are daydreaming or thinking about the past, planning for the future, or just reflecting on yourself, your DMN is running the show.
Okay, so that is the background mode. What about the salience network?
The salience network is your brain's threat detection and triage system.
Triage.
Yeah, it constantly monitors your internal and external environment, and it decides what pieces of sensory information actually deserve your immediate attention.
Give me an example.
If you are sitting in a quiet room, daydreaming, and suddenly a firecracker goes off right outside your window, your salience network flags that loud noise as a high-priority threat, and it violently pulls your attention toward it.
It wakes you up. Okay, and the third one, the sensorimotor network.
That is the network responsible for processing actual physical tactile sensations from the body and then initiating the appropriate motor response, like moving your limbs.
Got it. So in a healthy neurotypical brain, these networks essentially take turns. They have a polite, highly organized rotation.
Exactly.
Like when I'm sitting on the bus daydreaming about my weekend, the default mode network is on. But if a baseball suddenly flies toward my head through the window, the salience network detects the threat, immediately overrides and shuts down the daydreaming default mode, and alerts the sensorimotor network, which physically makes me duck.
That is a beautifully coordinated, perfectly healthy brain. The networks are functionally distinct. Activation of one network often requires the deactivation of another.
Okay, but when researchers put nociplastic pain patients into these functional MRI machines, they saw something completely different.
Completely different. The networks become tangled, they lose their polite boundaries, and we call this hyperconnectivity, or enmeshment.
Meaning they're all firing at the exact same time.
Yes. The default mode network, the salience network, and the sensorimotor network are communicating and firing together constantly, even when the patient is just lying perfectly still in the scanner with their eyes closed.
Oh my God, that is terrifying to think about.
It is overwhelming.
The brain literally cannot separate the relaxed daydreaming state from the high alert threat detection state from the physical sensation of movement. They all blur together into one constant, deafening static of background noise.
Exactly. And honestly, no wonder people experience crippling brain fog and systemic fatigue.
Right. Your brain is running three massive, energy-intensive software programs simultaneously, 24 hours a day.
The metabolic toll is immense. And we can actually measure the chemical footprint of this constant firing, too.
How so?
Advanced imaging techniques like magnetic resonance spectroscopy, they allow us to look at the exact concentration of specific neurochemicals in these specific brain regions.
Basically looking at the fuel and the brakes.
Precisely. The brain operates on a very delicate balance of neurotransmitters.
Huh.
The two major players here are glutamate and GABA.
Okay, glutamate and GABA, what do they do?
Glutamate is an excitatory neurotransmitter. It is the chemical fuel that makes neurons fire and transmit signals.
Okay.
The fuel. And GABA, or gamma-aminobutyric acid, is an inhibitory neurotransmitter. It is the chemical brake that calms the nervous system down and stops neurons from firing.
So what does the spectroscopy show in a nociplastic brain?
A profound, measurable imbalance.
In which direction?
We consistently see significantly elevated levels of excitatory glutamate in regions like the insula, which is heavily involved in processing pain.
So too much fuel.
Right. The brain is flooded with chemical fuel, causing the neurons to fire repeatedly and excessively. And conversely, we often see severely decreased levels of inhibitory GABA.
So the gas pedal is glued to the floor, and the brake lines have been completely severed.
Exactly.
But the dysfunction isn't just contained inside the skull, is it? It affects how the brain talks to the rest of the body. Because there's this incredible concept in pain science called descending pain modulation.
Yes, this is so important. It's one of the most elegant survival mechanisms in the human body.
How does it work?
Well, we usually think of pain as a signal traveling strictly up from the body to the brain.
Right, from the hand to the head.
But the brain isn't just a passive receiver. It actually has the power to send signals down the spinal cord to actively intercept and block pain signals before they even reach your conscious awareness.
The classic example of this is the soldier on the battlefield, right?
Exactly. A soldier gets shot in the leg during an intense firefight, but manages to sprint to safety, carry a wounded friend, and honestly doesn't actually feel the agony of the gunshot wound until hours later when they're sitting safely in the medic tent.
That is the descending pain modulatory system working flawlessly.
Yes. In that moment of extreme danger, the brain rapidly calculates that feeling severe pain in the leg would prevent the soldier from running, which would result in death.
So it turns the pain off.
Exactly. Regions in the brain send massive inhibitory signals down the spinal cord. They basically close the neurological gates. The brain says now is not a safe time to process this pain, and it chemically suppresses it.
But in nociplastic pain, this top-down gate control is broken.
Completely. The descending brakes fail. Functional connectivity between the areas of the brain that control this modulation is significantly reduced. The brain just loses its ability to turn the pain volume down.
But wait, it actually gets worse than just losing the brakes, doesn't it? Because the literature says the brain sometimes throws the system into reverse.
This is where central sensitization becomes truly insidious.
What happens?
Studies indicate that in many nociplastic pain states, instead of sending inhibitory signals to block the pain, the brain actively sends signals down the spinal cord to facilitate or amplify the incoming sensory messages.
The descending pathways actually make things hurt more.
Yes. The system designed to protect you by dulling pain during a crisis is now actively hunting for harmless signals and blowing them massively out of proportion.
The protector literally becomes the tormentor.
Exactly.
And this specific mechanism leads to what is arguably the most crucial and validating revelation for anyone who has struggled with pain medication. Let's talk about the opioid paradox.
It is a tragic misunderstanding that has caused untold suffering, especially in the context of the opioid epidemic.
So researchers did lumbar punctures, which are spinal taps, on patients with severe nociplastic pain like fibromyalgia to analyze their cerebrospinal fluid.
Right.
What were they looking for and what did they find?
They were looking at the neurochemical environment of the spinal cord, and they found significantly increased levels of endogenous opioids.
Endogenous meaning the body's own natural painkillers like endorphins and enkephalins.
Yes. The body is highly intelligent. It recognizes that it is in a state of chronic severe distress.
So it tries to fix it.
Exactly. The brain frantically attempts to put out the fire by flooding the central nervous system with its own natural opioids. It is maxing out its internal pharmacy trying to stop the pain.
But because the system is so deregulated and the descending brakes are broken, it's just not working. The pain persists anyway.
Right. And worse, the opioid receptors in the brain and spinal cord become completely saturated and eventually downregulate.
Meaning they become less responsive to opioids in general.
Yes.
So consider the clinical implication of this for a real patient. You have a patient in absolute agony. Their own body is already drowning in natural opioids that aren't working.
Right.
They go to a doctor who pulls out a prescription pad and prescribes a synthetic opioid pill, oxycodone, Vicodin, Percocet. What happens?
Best case scenario, it does absolutely nothing. The receptors are already full. Adding more opioids is like pouring water into a glass that is already overflowing. It just spills over.
Best case scenario. What is the worst case scenario?
The worst case scenario, which is incredibly common, is that the synthetic opioids actually make the pain significantly worse.
How does a painkiller cause more pain? That sounds crazy.
It triggers a condition called opioid-induced hyperalgesia.
Opioid-induced hyperalgesia.
Yes. The high dose of synthetic opioids further sensitizes the central nervous system. It paradoxically lowers the pain threshold even further, while simultaneously causing terrible side effects like severe cognitive fog, constipation, and of course, chemical dependency.
So, if you are listening to this right now and you have been prescribed opioids for chronic, widespread pain, and you have found that they just make you feel sick, groggy, or actually cause your entire body to ache more.
Which happens all the time.
Right. And your doctor looks at you like you are crazy or non-compliant. You need to know you are not crazy. It is a biological, neurochemical fact. Throwing heavy opioids at a nociplastic pain problem is literally pouring gasoline on a fire.
It is fundamentally the wrong tool for the job. You can't fix a software glitch with heavy hardware suppressants.
Right.
And the overarching comfort here is that all of this hard science, the fMRI showing enmeshed networks, the spectroscopy showing high glutamate, the spinal taps showing elevated endogenous opioids, it unequivocally proves that your pain is biologically verifiable.
The proof is in the software code, not the hardware casing.
Exactly. Even if the X-ray of your lower back is perfectly clear, the scan of your central nervous system reveals an intense, real pathology.
Which naturally leads to the next massive question. How does the software get corrupted in the first place?
That is the million-dollar question.
Because if we aren't born in agonizing pain, what causes the central nervous system to rewire itself so drastically?
Understanding the genesis of nociplastic pain requires looking at a very complex web of risk factors. There isn't just one cause.
Okay, what do the patterns show?
When we examine the epidemiology, the patterns of who actually gets these conditions, several very distinct biological and environmental drivers emerge. The most prominent one, which is immediately visible in the data, is sex.
There is a massive female predominance, right? Women are diagnosed with conditions like fibromyalgia, IBS, and chronic pelvic pain at drastically higher rates than men.
Drastically higher.
Is that just diagnostic bias, or is there an actual biological mechanism at play here?
Well, while medical bias against women's pain is a very real, heavily documented historical issue, there is an undeniable biological foundation here too.
What is it?
The hormonal differences play a massive role in shaping how the nervous system modulates pain. We see that sex differences in pain sensitivity are almost non-existent in childhood.
Really?
Yes, but they rapidly emerge during puberty, precisely when sex hormones surge.
What exactly are the hormones doing to the nerves?
The research on testosterone is fascinating. It appears that testosterone actually acts as a neuroprotective shield.
A shield.
Yeah. In animal models, if researchers completely remove testosterone from male mice, their sensitivity to widespread pain drastically increases.
Wow.
And if they administer testosterone to female mice, their pain sensitivity decreases. Testosterone naturally bolsters the pain inhibitory pathways.
So men essentially have a built-in biological buffer against central sensitization.
In many ways, yes.
What about estrogen then?
Estrogen's relationship with pain is highly complex and biphasic.
Meaning it goes both ways.
Exactly. At very high stable concentrations, such as during the later stages of pregnancy, estrogen actually has strong anti-nociceptive effects. It blocks pain.
Okay.
But at low concentrations, or more importantly during rapid fluctuations, estrogen withdrawal can severely enhance vulnerability to pain.
Which perfectly explains why so many women with nociplastic conditions report massive flare-ups in the days right before their menstrual cycle.
Precisely.
Or experience the onset of chronic pain during the really turbulent hormonal transition into perimenopause and menopause.
Exactly. The fluctuating estrogen destabilizes the nervous system's baseline.
Okay, so hormones are the soil, so to speak. Let's look at the seeds. What actually triggers the change?
One of the most critical psychological and environmental risk factors is early life stress and trauma.
The literature connecting adverse childhood experiences, or ACEs, to chronic illness in adulthood is undeniable at this point.
It is one of the most robust findings in all of psychosomatic medicine.
We are talking about experiences like physical or emotional abuse, severe neglect, the traumatic loss of a parent, or even just growing up in a household with severe substance abuse or violence.
Right.
But how does something that happens when you are, say, 7 years old cause widespread physical pain when you are 40?
It permanently alters the developmental trajectory of the brain. When a child is exposed to chronic severe stress, their developing nervous system is repeatedly flooded with cortisol and adrenaline, and the brain is incredibly adaptive, especially in childhood.
So it adapts to the stress.
Yes, it essentially says, okay, the environment we live in is highly dangerous. We need to be on alert at all times to survive. So the baseline for the salience network, that threat detection system we talked about, is permanently calibrated abnormally high.
The brain is permanently primed for danger.
Yes, the nervous system becomes structurally hypervigilant.
So fast forward 30 years.
Right, fast forward 30 years. That adult might experience a relatively standard stressor, a minor car accident, a stressful divorce, maybe a bad viral infection.
Okay.
But because their nervous system was already primed in childhood, it overreacts massively to this new trigger. And that tips them over the edge into a permanent nociplastic pain state.
The trauma literally altered the physical set point of their biology.
Exactly. It's a heavy, heartbreaking reality, but it connects so many dots for so many patients.
Beyond trauma and hormones, what are the actual lifestyle factors that push someone into this state?
Two of the most consistent and honestly highly modifiable lifestyle risk factors are physical inactivity and severe sleep disturbance.
The sleep research is absolutely wild. Can you detail the sleep deprivation studies for the listener? Because this shocked me.
Oh, it's brilliant. Researchers designed a beautifully simple yet brutal experiment. They took perfectly healthy individuals, mostly young adults with absolutely zero history of chronic pain.
Healthy people.
Healthy people. They brought them into a sleep laboratory. They allowed them to fall asleep naturally, but they monitored their brain waves via EEG.
Okay.
The moment these healthy subjects entered slow-wave, deep sleep, which is the most restorative phase, the researchers would introduce a disturbing stimulus, like a sudden, loud noise, just enough to bump them out of deep sleep into a lighter stage of sleep without fully waking them up.
So they are technically asleep the whole night, their eyes are closed, but they are getting zero deep restorative rest.
Exactly. And the results were completely astonishing. Within just a few days of this targeted sleep disruption, these perfectly healthy individuals began to develop the cardinal symptoms of fibromyalgia.
In just a few days.
Yes. They reported widespread muscle tenderness, severe fatigue, mood irritability, and measurably decreased pain thresholds.
Just stripping away deep sleep was enough to mimic a severe chronic pain condition.
It proves how deeply intertwined sleep architecture is with the brain's ability to maintain those descending pain breaks we talked about earlier. If you don't sleep, the breaks physically disintegrate.
It is a vicious cycle, isn't it? Poor sleep breeds pain, and then the pain prevents good sleep.
It is a terrible feedback loop, and this works synergistically with physical inactivity.
A sedentary lifestyle.
Right. When we engage in moderate physical exercise, our muscles naturally release a cascade of anti-inflammatory myokines, and our brains release endorphins and endocannabinoids.
So exercise is natural pain medicine.
Exactly. Regular movement actively nourishes and strengthens the descending pain inhibitory pathways. When a person is completely sedentary, they literally starve their brain of its natural pain modulation tools.
Okay, so we have hormonal fluctuations, early childhood trauma, poor sleep architecture, and lack of movement.
Right.
But there is one more major catalyst. What happens when someone has traditional, hardware-based nociceptive pain for a very, very long time?
That is the concept of accrued pain, or the spillover effect. Having a poorly managed nociceptive condition is a massive risk factor for eventually developing nociplastic pain.
Let's use severe rheumatoid arthritis as an example of this.
Perfect example. Rheumatoid arthritis is an autoimmune condition where the immune system attacks the linings of the joints.
Right.
It causes massive localized inflammation and actual tissue destruction. It is highly painful, but it is classically nociceptive. The pain originates at the damaged joint. However, If that patient goes undertreated for 5, 10 years, those localized nociceptors in their hands and knees are firing danger signals into the spinal cord 24 hours a day, 7 days a week.
Going back to our alarm analogy, the alarm in the kitchen has been shrieking nonstop for a decade. Eventually, the central control panel on the wall is just going to fry.
Exactly. The constant bombardment of pain signals literally exhausts the central nervous system. The dorsal horn of the spinal cord undergoes actual neuroplastic changes, becomes structurally sensitized.
So 5 years in, what happens?
Well, the patient still has terrible joint pain in their hands from the arthritis, but now they also have widespread aching in their back and shoulders. They have terrible brain fog. They have allodynia. The localized hardware problem has successfully corrupted the central software.
That transition is terrifying, but it brings up a really important question about the immune system. We hear so much about systemic inflammation. Every health podcast talks about inflammation. In this spillover effect, or nociplastic pain in general, is the immune system actively attacking the brain.
It is a cutting-edge area of research, and the neuroimmune link is fascinating.
How does it work?
Well, it's not an attack in the classic autoimmune sense, like multiple sclerosis, where immune cells actively destroy the myelin around nerves. Instead, it's a highly dysfunctional conversation between the immune system and the nervous system. The key players here are glial cells.
Glial cells, those are the support cells in the brain, right?
Yes, specifically microglia and astrocytes. They are the brain's resident immune sentinels and basically the cleanup crew. Normally, they just perform background maintenance.
Okay, they just sweep the floors.
Right. But under chronic stress, or when they're bombarded by continuous pain signals, these glial cells become activated. They actually change physical shape. They shift from a supportive role to a defensive, highly aggressive role.
What do they do when they get aggressive?
They begin secreting pro-inflammatory cytokines, which are chemical messengers of inflammation, directly into the central nervous system and the cerebrospinal fluid.
So they just bathe the brain in inflammation.
Exactly. This neuroinflammation makes the neurons incredibly hyperexcitable. It massively drives central sensitization.
And there was a landmark study that proved just how powerful this immune connection is involving humans and mice. Walk us through that experiment because the implications are genuinely staggering.
It truly shook the pain research community to its core. Researchers wanted to see if the immune system alone could transfer the nociplastic state from one organism to another.
How do you even test that?
They took blood samples from human patients suffering from severe fibromyalgia. They isolated the IgG antibodies, which are specific immune system proteins, and purified them.
So they have little vials of concentrated immune proteins from people in severe chronic pain.
Yes. Then they injected these human fibromyalgia antibodies into perfectly healthy, pain-free mice.
And what happened to the mice? Wait, how do you even measure pain in a mouse?
You basically measure their withdrawal reflex to pressure and temperature.
Okay.
After receiving the human antibodies, the previously healthy mice rapidly developed profound hypersensitivity. They exhibited allodynia, withdrawing from very gentle touches that previously didn't bother them at all.
Wow.
Their nociceptors became highly responsive, and they even showed decreased locomotor activity, which is essentially mouse fatigue.
The healthy mice literally, quote-unquote, caught fibromyalgia just from receiving the human immune proteins.
Exactly. Now, to be scientifically rigorous, I must add that this is an active debate in the literature. A subsequent high-profile study attempted a similar process, but pointed the finger at a different part of the immune system, specifically neutrophils, which is a type of white blood cell infiltrating the sensory ganglia, rather than the IgG antibodies themselves.
Right.
But the specific cellular actor isn't really the main point for our listeners. The profound conclusion is exactly the same. The immune system is fundamentally entwined with the nervous system, and it is entirely capable of actively driving and transferring this nociplastic pain state.
It is a full-body systemic event. It's not just a sore muscle. It's a massive biochemical cascade involving hormones, brain networks, spinal fluid, and immune sentinels.
Precisely.
Now, because the genesis of this condition is so complex, researchers have realized that not all nociplastic pain is the same. They have identified two distinct clinical flavors, so to speak.
Yes, and for a patient navigating treatment, understanding which subtype they actually have is arguably the most important piece of the puzzle. We broadly categorize nociplastic pain into bottom-up and top-down.
Let's start with bottom-up. That sounds a lot like the spillover effect we just talked about with the arthritis.
It is exactly that. Bottom-up nociplastic pain always starts with a very real, clearly identifiable peripheral physical injury, a major nociceptive driver.
Give us an example.
Let's use the example of severe bone-on-bone osteoarthritis in a patient's hip.
The hip cartilage is completely gone. The hardware is destroyed.
Right, and because that destroyed hip has been sending screaming pain signals to the spinal cord for years, the central nervous system has become fully sensitized.
So the software glitches.
Exactly. The patient now presents with the whole nociplastic cluster. They have a terrible hip pain, but they also have widespread body aches, they have exhaustion, brain fog, and poor sleep. The problem started at the bottom, in the periphery, and worked its way up to corrupt the central brain networks.
Okay, so mechanically speaking, if the hardware caused the software glitch, what happens if you actually replace the hardware?
This is the magic of the bottom-up subtype. If that patient undergoes a successful total hip replacement and the surgeon completely removes the arthritic joint, the primary nociceptive driver is completely gone.
The screaming signals finally stop.
Right.
But does the central sensitization go away? The software is already corrupted.
In about 2/3 of these specific bottom-up patients, yes, it does.
Really?
It takes time, but once that relentless input is silenced, the central nervous system slowly resets itself. The glial cells calm down. A year after the hip surgery, the patient doesn't just have a pain-free hip. Their widespread body pain disappears, their fatigue lifts, their brain fog clears.
Wow. Removing the bottom-up driver allows the top-down system to heal.
Exactly.
That is incredible. Fixing the localized hardware actually cures the systemic software glitch. But that's only one flavor. What about top-down nociplastic pain? Because that sounds much harder.
Top-down nociplastic pain is a completely different beast.
Let's imagine another patient, say Sarah. How does Sarah's top-down pain start?
It usually begins much earlier in life, often around puberty or young adulthood. And crucially, it almost always begins without any massive, identifiable peripheral physical injury.
So there is no destroyed hip. There is no shattered ankle for Sarah.
None.
So what triggers it?
It is heavily driven by the other risk factors we discussed: genetic predisposition, early life trauma, chronic stress, and pre-existing sensory hypersensitivities.
Yeah.
In top-down pain, the central nervous system itself is generating the pain state completely independently, right from the very start.
The brain is the primary autonomous driver.
Yes.
As the old horror movie trope goes, the call is coming from inside the house.
Precisely. And this distinction is where clinical decision-making becomes a matter of immense, life-altering consequence.
How so?
Imagine Sarah with top-down nociplastic pain. Her brain is generating a massive pain signal. But because the brain has to project that pain somewhere, let's say she feels it intensely localized in her lower back.
Okay. So she goes to an orthopedic surgeon.
Right. And the surgeon takes an MRI of her lower back. The MRI shows some very mild, age-appropriate disc degeneration.
Nothing that should cause agonizing screaming pain.
Exactly. But Sarah is demanding relief, and maybe the surgeon is overly aggressive. The surgeon decides to go in and perform a major lumbar spinal fusion, attempting to fix a hardware problem that isn't actually the true source of the pain.
Oh no, what happens to Sarah?
The surgery almost universally fails. Sarah wakes up, she recovers from the major incision, and the agonizing back pain is still right there.
Because they fixed hardware that wasn't broken.
Exactly. In fact, it's often significantly worse because the severe physical trauma of having your spine sliced open and bolted together further traumatizes and sensitizes the nervous system. The widespread pain, the fatigue, the brain fog, absolutely none of it improves. The peripheral tissue was never the root cause.
This highlights why this entire conversation is so utterly critical. Identifying whether your pain is top-down or bottom-up literally saves you from undergoing unnecessary, agonizing, expensive, and ultimately destructive surgeries.
Absolutely. If your pain is top-down, you cannot treat the software problem with a scalpel. You have to treat the brain.
Exactly. Which brings us to the ultimate question for everyone listening right now, the roadmap to relief.
Let's get to the solutions.
We know what it is, we know how it works, we know what causes it. How do we actually fix it? How do we recalibrate the central nervous system?
Well, the treatment paradigm for nociplastic pain is entirely different from acute pain. Let's start with the pharmacological side. We've already established what not to do. Traditional NSAIDs like ibuprofen or naproxen, they do absolutely nothing for central sensitization because they only target localized peripheral inflammation.
Right.
And we've exhaustively covered why opioids are contraindicated and often make it worse.
So if someone is in so much pain they simply cannot function and they need a pharmaceutical intervention just to get out of bed, what classes of medication actually target the central nervous system?
We look to medications that actively modulate the neurotransmitters in the brain and spinal cord. We are trying to restore that glutamate and GABA balance and strengthen those broken descending inhibitory brakes.
What are the frontline options for that?
Interestingly, the most effective pharmacological tools are often low-dose tricyclic antidepressants, like amitriptyline.
Arabactapras.
Yes. We also frequently utilize SNRIs, which are serotonin norepinephrine reuptake inhibitors, like duloxetine, which is marketed as Cymbalta, or milnacipran.
Now, hold on a second. I can hear the listener's internal monologue right now. They are thinking, wait a minute. We just spent 50 minutes proving that this pain isn't in my head, that it isn't a psychiatric invention. And now the very first thing you want to prescribe me is an antidepressant. That feels like a massive betrayal.
It is a completely understandable reaction, and honestly, doctors often do a terrible job of explaining it to patients. We have to separate the marketing category of the drug from its actual hard biological mechanism of action.
We are not prescribing these to treat depression then.
No, though if depression is present, it obviously may help,
Mhm.
but that's not the primary goal.
So what are these drugs physically doing to the spinal cord?
SNRIs massively increase the availability of serotonin and norepinephrine in the synaptic clefts of the central nervous system.
Okay.
These specific neurotransmitters happen to be the exact chemical messengers used by the descending pain inhibitory pathways. By increasing their concentration, we're directly strengthening the brain's physical ability to turn the pain down signals to the spinal cord.
Oh, wow.
We are literally chemically fixing the broken biological brakes.
That makes so much sense when you explain it like that. It's a neurochemical, mechanical fix. The fact that the drug also happens to treat depression is just a side effect of how neurotransmitters work in different parts of the brain.
Precisely. In fact, clinical trials for fibromyalgia have explicitly proven that the pain-relieving effects of SNRIs occur entirely independently of whether the patient actually has clinical depression or not.
That is fascinating. What other drugs work?
Another class of medications we use are gabapentinoids, like pregabalin or gabapentin.
How do those work?
They bind to specific calcium channels on the hyperactive nerves, essentially dampening the release of excitatory neurotransmitters like glutamate. They calm the electrical storm.
Okay.
But, and this is a massive caveat that every major medical consensus guideline emphasizes, pharmacological treatments for nociplastic pain generally only have modest efficacy.
So they aren't a cure.
No, they are rarely a silver bullet. They should be viewed purely as a tool to turn the volume of the pain down just enough, maybe 20 or 30%, so that the patient has the physical and mental bandwidth to engage in the real gold standard treatments.
Which are the non-pharmacological neuroplasticity-driven therapies? Let's get into the gold standards because this is the real work.
Yes.
And incredibly, number one on the clinical list is education. Just learning the neuroscience of pain.
Exactly.
Which means just by listening to this deep dive right now, the listener is literally engaging in a validated medical treatment.
It sounds almost too simple to be effective, but it is rigorously scientifically proven. The clinical term is explain pain, or pain neuroscience education.
But how does simply learning a biological concept actively reduce physical pain? That sounds like magic.
It goes right back to the salience network, the brain's threat detector. When you have severe, unexplained chronic pain and doctors keep telling you they don't know what's wrong, your brain interprets that as a massive, ongoing existential threat to your survival.
Right, the brain panics.
It panics. It amplifies the pain signal to force you to rest and protect yourself from this terrifying unknown danger. The fear of the pain actively fuels the pain.
But once you understand the mechanics of nociplastic pain...
Exactly. Once you truly internalize that the pain is a false alarm, that your tissues are actually safe, your spine is not crumbling, your muscles are not tearing apart, the cognitive threat level just plummets.
The conscious brain tells the subconscious threat detector, hey, we are safe, the alarm is just glitching, but the house is not actually on fire.
That cognitive realization measurably reduces the biological threat response, which in turn literally lowers the volume of the pain generated by the brain. Knowledge literally rewires the neural pathways.
That is the ultimate empowerment. Education is an analgesic.
It absolutely is.
Okay, what is gold standard number 2?
Sleep therapy. We established earlier that fragmented sleep physically destroys the descending pain brakes. Therefore, fixing sleep architecture is a massive, indispensable lever for pain reduction.
But when we talk about fixing sleep for someone in chronic pain, we aren't just talking about basic sleep hygiene, right? It's not just, hey, make sure your room is dark and drink some chamomile tea before bed.
No, basic sleep hygiene is necessary, but it is entirely insufficient for a nervous system that is locked in a hyper-aroused state. The gold standard intervention here is cognitive behavioral therapy for insomnia, or CBTI.
Let's explore CBTI. How is it different from just popping a sleeping pill?
Well, sleeping pills artificially sedate you. They rarely produce the deep, restorative, slow-wave sleep the brain actually needs to heal.
Right.
CBTI is a highly structured, rigorous behavioral program that breaks the psychological and physiological cycles of insomnia. People in chronic pain often develop terrible sleep anxiety. They lie in bed, in pain, staring at the clock, terrified of how exhausted they will be tomorrow. That bed literally becomes associated with stress, not rest.
How does CBTI break that association?
Through intense techniques like sleep restriction therapy and stimulus control. For instance, if you are lying in bed awake for more than 20 minutes, you are strictly required to get out of bed, go to another room, and do something incredibly boring until you're incredibly sleepy, and only then return to bed.
That sounds exhausting in itself.
It is hard work, but it painstakingly retrains the brain to subconsciously associate the mattress exclusively with rapid, deep sleep rather than anxiety and pain.
And does it work for the pain?
Studies show that successful CBTI drastically reduces not only fatigue, but actual pain severity and brain fog in nociplastic patients.
So we have education to lower the threat response and CBTI to restore the neurological brakes. What is the final pillar of the gold standard?
Movement, specifically graded, gentle, physical activity.
Okay, stop right there.
I know.
If someone is listening to this during a massive flare-up when it feels like their muscles are bruised and their joints are literally filled with battery acid, telling them to go for a walk feels insulting.
Of course it does.
It feels completely counterintuitive to move a body that is screaming in pain.
And that reaction is 100% logical based on a lifetime of learning how normal nociceptive pain works. From the time we were toddlers, we learned that if you twist your ankle, walking on it damages it further. Pain means stop. Pain equals tissue damage.
Right. So why force movement now?
Because with nociplastic pain, we know definitively that the tissue is safe, the pain is a false alarm. However, because the central nervous system is so hypersensitized, any novel sensory input, like the gentle stretching of a hamstring or the mild impact of a footstep, is misinterpreted by the brain as dangerous.
And it triggers a massive pain response.
Exactly.
So how do you possibly overcome that? How do you trick a hypervigilant brain into letting you exercise?
You have to meticulously, patiently train the brain that movement is safe. And we do this through a specific behavioral framework called time-contingent pacing, which is the exact opposite of what most people do, which is pain-contingent pacing.
Let's dive really deep into the mechanics of time contingent versus pain contingent. This sounds crucial.
It is the key to everything physical. Pain-contingent pacing is our default human setting. You decide to try and exercise, you go for a walk, you walk until the pain in your back or legs gets too intense, and then you stop and go home.
That seems like common sense. Listen to your body.
It seems like common sense, yes, but neurologically, it is disastrous for nociplastic pain. Think about the operant conditioning that just occurred in your brain.
Yeah.
Your brain did not want you to move. So it generated a pain signal. You ignored it and kept moving. So the brain panicked and generated a louder, more severe pain signal. You finally gave up and stopped moving. You just rewarded the brain for producing pain. You taught your central nervous system that if it hurts you severely enough, you will stop the scary activity.
Oh my God. It's like training a dog. You just gave the nervous system a treat for biting you. You reinforced the very pathway you are trying to break.
Exactly. Time-contingent pacing completely flips the script and hacks the conditioning.
Yeah, how do you do it?
You start by determining a baseline amount of activity that you can do completely comfortably without triggering a flare-up. Let's say that is just a very slow 3-minute walk.
Just 3 minutes.
Yes. You set a timer for 3 minutes. You walk, and the very moment that timer goes off, you stop.
Even if I feel fine.
Even if you feel fantastic, even if you want to keep going for another 10 minutes, you stop.
You surrender control to the clock, not the pain.
Yes. What does this teach the hypervigilant brain? The brain realizes, hey, we engaged in physical activity. We moved the muscles. And then we stopped safely. And I didn't have to generate a massive pain signal to force us to stop.
Wow. You are proving to the salience network that movement does not equal danger.
Exactly. Over weeks and months, you slowly, incrementally increase the timer. 4 minutes,
Yeah.
5 minutes, 10 minutes. You are literally structurally rewiring the brain's association with movement.
That is absolute genius. I mean, it obviously requires an agonizing amount of patience, especially on days when you feel good and want to push yourself. But the neurological logic is undeniable. Stop when the timer says stop, not when the pain says stop.
It is the single most effective way to restore physical function and rebuild endurance without triggering those massive push and crash cycles that plague so many chronic pain patients.
This has been an incredibly dense, profound journey through the human nervous system today.
We really covered a lot of ground.
We have covered the history of pain, the clinical symptoms, the deep neuroscience of brain networks and neurochemicals, the risk factors, the subtypes, and a roadmap to relief. For everyone listening, I deeply hope this provides a massive, tangible tool for self-advocacy.
That is the ultimate goal.
Because the next time you are sitting in a doctor's office and they look at your perfectly clear MRI and give you that condescending smile and say, well, everything looks completely normal, there's nothing physically wrong with you, you do not have to shrink into your chair anymore,
You have the vocabulary now.
you can look right back at them and confidently say, I know the scans are clear, the hardware is fine, this is a central nervous system sensitization issue, I have nociplastic pain. Now, how are we going to treat my software?
That is the beautiful transition from being a helpless medical mystery to being an empowered patient with a recognized, highly specific neurobiological condition.
But before we completely close out this deep dive, I want to leave you, the listener, with a slightly more philosophical thought to ponder.
Let's explore it.
Something that struck me deeply as I was immersed in the evolutionary biology of all this material. Evolutionary biology dictates that pain is a fundamental survival mechanism, right? It is the ultimate protector. It kept our ancestors alive.
Where you touch a fire, you pull away.
Exactly. You touch the burning embers, you feel pain, you pull your hand away so you don't burn to death. It is designed purely to preserve the organism. But nociplastic pain is that exact same ancient protective system running completely wild, sounding the alarm and destroying quality of life when there is zero actual harm present.
It is the ultimate paradox. The protector literally becomes the destroyer. It is a biological defense system that has become hypervigilant to the point of self-sabotage.
Right, so if the very system designed to protect us is now generating endless pain independently, is chronic nociplastic pain effectively the human nervous system becoming allergic to itself?
Wow, allergic to itself.
Are we living in a modern world that is so highly stressed, so chronically sleep-deprived, so fundamentally traumatized that our ancient survival mechanisms are quite literally short-circuiting on a mass scale? What does it truly mean for the future of humanity if the biological alarm system designed to keep us alive is rapidly becoming one of the leading causes of modern human suffering?
That is a very profound, sobering question to end on. It strongly suggests that our modern lifestyle and environment are fundamentally dangerously mismatched with our ancient neurobiology.
It is absolutely something to seriously think about. So the next time you're sitting in that clinic and the doctor holds up that perfectly clear x-ray, just remember, the invisible does not mean it isn't real. The broken bone might not be there, but the glitch in the alarm system is screaming. And now you finally have the blueprint to start turning the volume down.